Welcome to the following presentation on the functional anatomy and biomechanics of the lumbar spine. Let's consider some of the features of a typical lumbar vertebrae. The vertebral body is kidney-shaped, and there is slight anterior wedging, the anterior part being meant for weight-bearing. The superior and inferior surfaces of the vertebral body are essentially flat, dedicated to supporting longitudinally applied loads. The vertebral body and the intervertebral discs are responsible for 80% of the static compressive load in the erect posture. Looking at the posterior elements, we can see the transverse processes, which are long and flat. L3 tends to be the longest and L1 the shortest. The transverse process is at the level of the superior end of the spinous process, and this is an important point to note for our palpation skills. The spinous processes in the lumbar spine are large and hatchet-shaped. The spinous process of L5 is the smallest. They project straight backward from the junction of the right and the left lamina. The internal architecture of the vertebral body reflects its weight-bearing function. We have a cancellous core which is covered by a thin cortical shell. The analogy described by Toomey and Taylor is that if we had just a shell of cortical bone, the vertebral body would be like a box and it would collapse if a load was applied. The internal vertical struts brace the box, and bowing of the struts resists collapse of the box. The transverse struts will prevent the vertical struts from bowing and increase the load-bearing capacity of the box. So the vertical and horizontal trabeculi are important for weight-bearing strength and resilience of the vertebral body. The load will first be borne by the vertical trabeculi, and when these attempt to bow, they are restrained further by the horizontal. The advantages of this is that we have a strong, lightweight, load-bearing structure, and the space between the trabeculi can be used as channels for blood supply and venous drainage. A condition that affects the horizontal trabeculi is osteoporosis, and this affects the load-bearing capacity of the vertebral body. The vertebral foramen transmitting the nervous structures varies in shape. It is oval in the upper lumbar levels, becoming more triangular as we move caudally. The shape that it assumes at the lower lumbar levels is a trefoil shape, meaning that it is triangular and the angles are stretched or accentuated. The picture on the left shows how the shape of the vertebral foramen varies as we move from the cervical, thoracic, and into the lumbar region. We can see that in the cervical, the vertebral foramen is again triangular, whereas in the thoracic spine, it tends to be smaller and circular. The size and shape of the vertebral foramen can be abnormally small due to alterations in the development of the neural arch. The pedicles may be too thick, or the articular processes may be too large. The space then left for the vertebral canal becomes relatively small. This is known as congenital or developmental stenosis. Acquired spinal stenosis can result when structures surrounding the vertebral canal are affected by disease or degeneration. Examples could include disc herniations, buckling of the ligamentum flavum, or osteophytes. Posteriorly, the pedicles are two stout pillars of bone which project from the back of the vertebral body. Their function is to transmit both tension and bending forces, and the tubular design allows them to be able to sustain these forces. All forces which are sustained by any of the posterior elements are ultimately channeled towards the pedicle. The lamina project from each pedicle towards the midline, and they meet and fuse in the middle. They form the roof of the neural arch. The function of the lamina is that it provides a protective covering over the neural contents of the vertebral canal, and it also transmits forces. Stability of the lumbar spine can be compromised with disease or injury of the lamina. The pars interarticularis is the part of the lamina between the superior and inferior articular processes. It lies at the junction of the vertically orientated lamina and the horizontally projecting pedicle. It is subject to considerable bending forces, and it consists of thicker cortical bone. In some individuals, it is insufficiently thick and is susceptible to fatigue or stress fractures. On the right in this slide, you can see a defect in the pars interarticularis, leading to spondylolisthesis. The lumbar zygapophyseal joints are synovial joints formed by the articulation of the convex articular surface of the inferior articular process of the vertebrae above with the concave articular surface of the superior articular process of the vertebrae below. The superior articular process faces posteriorly medially, and the inferior articular process faces anteriorly and laterally. The Z joints are biplanar in cross-section and are comprised of a coronal component, which is the anterior medial third, and a sagittal component, which is the posterior lateral two-thirds of the joint. The anterior third is orientated in the coronal plane and limits forward translation of the upper vertebrae. The posterior third is orientated in the sagittal plane and prevents or restrains axial rotation. The picture on the left shows the gradual change in orientation of the Z joints from L1 down to L5. The sagittal component tends to be largest at L1-2, whereas the coronal component is largest at L5-S1. The lumbar facets are originally flat in the coronal plane in infants, resembling cervical and thoracic facets. In adults, they become curved or biplanar in the transverse plane. Throughout childhood, they develop their adult shape by gradually adding on the sagittally orientated portion. This occurs as the facets increase in size by posterior growth from the lateral margins. The shape of the articular facets varies. They can be planar, C-shaped, or J-shaped. J-shape tends to be the more common, with the anterior medial component being coronally orientated and the larger posterior component being orientated in the sagittal plane. The functions of the zygapophyseal joints are as follows. 1. They serve as guide rails for sagittal and coronal plane movement. 2. They restrain axial rotation and excessive translation. And 3. They protect the disc from torsional and shearing strains. The next two slides illustrate how the facet orientation protects the lumbar disc. If we have a coronal orientation of the facets, this will prevent forward translation, but it will favor axial rotation. A more sagittal orientation will allow forward translation, but resist axial rotation. A biplanar orientation, as we see here, will limit both forward translation and axial rotation, and therefore protect the intervertebral disc from both twisting and shearing forces. The angle formed by the superior articular process with the median plane shows an increase in this angle from L1 to S1. The joint planes become more coronal as we move caudally. The intersegmental angular change is greatest between L4 and L5, and this may relate to the increase in the lumbar lordosis as we approach the lumbosacral junction. Which vertebral body is this in the lumbar spine? Well, if you guessed that it was L5, you are correct, and there are a few features which would lead us to this conclusion. One is the shape of the vertebral foramen, number 6. It is trefoil in shape, indicating that this is lower in the lumbar spine. The second is the coronal orientation of the facets, number 3. And the last is that the fifth lumbar vertebrae is unique in that the transverse processes unite directly with the side of the vertebral body as well as with the pedicle. Bilateral asymmetry of the Z joints is common in the lumbar spine, and it can be a contributory cause of low back pain. It is most frequent at the lower two lumbar levels and is present in 23% of asymptomatic individuals. Developmental asymmetry may lead to backache as a consequence of asymmetrical mechanical forces acting on the motion segment. Ligamentum flavum forms the anterior medial portion of the joint capsule. It is made of elastic tissue and it helps approximate the anterior part of the joint and therefore contributes to stability. The posterior capsule is thinner than the anterior, but it is extensive. Some fibers of multifidus attach to the posterior part of the capsule and therefore exercise a tension on it. The attachment of multifidus lies very close to the joint line, and so therefore it is a stabilizer of the Z joint, as well as an extensor of the spine. There are three types of interarticular structures that can be found within the zygapophyseal joints in the lumbar spine. They are connective tissue rims, adipose tissue pads or fat pads, and fibroadipose meniscoid structures. The connective tissue rims are the smallest, and these are wedge-shaped thickenings of the internal surface of the capsule. The adipose tissue pads or the fat pads are found at the anterosuperior and the inferior posterior poles of the joint. They consist of a fold of synovium enclosing some fat and blood vessels. They project into the joint cavity for a short distance, and the fat moves freely in and out of the joint through the hole in the capsule as the joint moves. This provides a dampening or a lubricating mechanism to facilitate movements and to cushion the downward movement of the inferior articular process in extension. The fibroadipose meniscoid structures are the largest and they project up to 5 millimeters into the superior and inferior aspects of the joint cavity. They also consist of a fold of synovium, which encloses fat, collagen, and some blood vessels. The functions of these interarticular structures are 1. They act as space fillers. 2. They increase the surface area of contact when the articular facets are impacted and help to transmit load. And 3. They protect the articular surfaces as they become exposed during the extremes of flexion and extension. The next few slides are courtesy of Dr. Taylor and illustrate some of these interarticular structures. Here we can see a vascular, innervated, fatty synovial fold projecting between the articular surfaces of a zygapophyseal joint. These synovial folds or fat pads contain vessels and nerves, and they can become inflamed and painful. Synovial fold inflammation may be caused by trauma or by irritation from joint debris such as we would find in an arthritic joint. Some joints with enlarged fat pads are actually unstable, and the extension of the fat pad right through the joint appears to be an attempt to fill up the space or the gap in a so-called loose joint. An intra-articular inclusion is capable of locking the Z joint, much like a meniscus in the knee. A fibrocartilaginous inclusion can be formed by a tearing off of the posterior part of the articular cartilage. Clinically, what would we see? If this inclusion was, for example, at the right Z joint of L4-5, we would find movements which compress the joint would be painful, such as extension, right side flexion, going into the right extension quadrant, and left rotation, which would compress the zygapophyseal joint. On our PIVM testing and passive accessory glides, we may find a springy end feel. The treatment of choice in this case would be to gap the joint, to do an oblique gap technique. The articular cartilage is approximately 1 millimeter thick, and it is supported by plates of compact subchondral bone. This supporting bone plate is thick, approximately 14 millimeters in the coronal part of the joint, and thinner, 5 millimeters in the sagittally orientated posterior part of the joint. Different types of age-related changes can occur in the lumbar facet joints. Chondromalacia is frequently seen in the coronal components of the superior articular processes in young adults. This is a common site of stress, and it is also a response to the compressive loading that occurs with flexion and anterior translation. With aging, we can also see hypertrophy of the facets, thickening and sclerosis in the anterior coronal part of the subchondral bone plate, as well as an increase in the size of the facets with formation of marginal osteophytes. Osteoarthritic type changes can also be seen, including fibrillation of the articular cartilage and a complete loss of the articular cartilage. This is unusual in the coronal component of the facet, but is more often seen in the sagittal section. In this cross-section, we can see a thickening of the subchondral bone plate as well as chondromalacia type changes in the anterior medial part of the joint. In this slide, we can see fibrillation of the articular cartilage as well as cartilage loss affecting the posterior part of the joint. Lumbar facet joint injuries, according to Dr. Taylor, include the following: soft tissue injury with hemarthrosis, microfractures of the articular surfaces with hemarthrosis, central vertical fractures of the superior articular process, and fractures of the mammillary process. The next 3 slides illustrate some of these facet joint injuries. Here we can see fractures through the facet. In this picture, we can see a fracture of the subchondral bone plate and articular cartilage with local hemorrhage. And here we can see injury to the central articular cartilage. Soft tissue injuries of the lumbar facets include capsular tears, ligamentum flavum tears, separation of the articular cartilage, or fracture of the articular cartilage with hemarthrosis. This slide illustrates a posterior fibrous capsule tear where it attaches to the posterior articular cartilage. Sprains and tears of the posterior capsule are quite common. Can you identify the ligamentous structures on this slide? This is the anterior longitudinal ligament, and it is a long band covering the anterior aspects of the vertebral bodies and the intervertebral disc. It consists of several sets of collagen fibers. Short fibers span each interbody joint, covering the intervertebral disc and attaching to the margins of the vertebral bodies. The more superficial layers cover 2 to 5 segments. The ligament is secondarily attached to the concave surface of the vertebral body, and this concavity is filled with areolar tissue, blood vessels, and nerves. The anterior longitudinal ligament is only loosely attached to the front of the annulus fibrosus. What is the function of the anterior longitudinal ligament? It resists extension and bowing of the lumbar spine, and it also assists in limiting anterior and posterior translation. The ligament on the right is the posterior longitudinal ligament, and this forms a narrow band over the backs of the vertebral bodies, but it expands out laterally over the backs of the intervertebral disc to give it a sawtoothed or denticulated appearance. Its fibers mesh with the annulus fibrosus to attach to the posterior margins of the vertebral bodies. What is the function of the posterior longitudinal ligament? It is much weaker than the anterior longitudinal ligament. It may resist separation of the posterior ends of the vertebral bodies. Adams, however, believes that it does not play a very significant mechanical role. in protecting the intervertebral disc from flexion injury, but that it may serve to deflect any prolapsed disc material away from the spinal cord. It has nerve endings, so perhaps it acts as a nerve net to detect abnormal deformation of the underlying disc. The interspinous ligament is a broad membrane which connects adjacent spinous processes. It is comprised of three different sets of fibers: ventral, middle, and dorsal fibers. The major set of the fibers originate from the lamina and pass upward and backward to insert into the underside of the spinous process above. The supraspinous ligament is a strong fibrous cord, and it connects together the spinous processes from C7 down to the L5. It lies in the midline, and the lower limit is the L5 spinous process. It is thicker and broader in the lumbar region and has superficial and deep fibers, the deepest connecting the spines of neighboring vertebrae. The fibers of the interspinous and the supraspinous ligament are interconnected, and mechanically they should be considered as a unit. When considered together, they provide 19% of the motion segment's resistance to flexion. They are the first structures to be damaged in a hyperflexion injury. The supraspinous ligament connecting the spinous processes can be seen here. The intertransverse ligament consists of sheets of connective tissue extending from the upper border of one transverse process to the lower border of the transverse process above. The appearance is more like that of a membrane, and the collagen is not very densely packed. Laterally, the intertransverse ligament divides into two layers. The anterior layer is continuous with the anterior layer of the thoracolumbar fascia. The posterior layer blends with the aponeurosis of the transversus abdominis to form the middle layer of the thoracolumbar fascia. Ligamentum flavum is a strong, extremely extensible ligament. It is short and thick and attaches adjacent lamina. Its attachment extends from the articular capsule to the region where the lamina fuse to the spinous processes. It is made up of 80% yellow elastic fibers and 20% collagenous fibers. Its primary mechanical function is to provide a smooth posterior lining to the spinal canal, one that does not become slack or buckle in lordotic postures. It also provides 13% of the resistance to flexion, and it helps to restore the flexed lumbar spine to an extended position. It also has a unique function in that the lateral division of the ligament prevents the anterior capsule of the facet joint from being nipped within the joint cavity during movement. Up to 5 bands have been described of the iliolumbar ligament. Bogduck in 1997 described an anterior, a superior, a posterior, an inferior, and a vertical band of the iliolumbar ligament. Willard in 2007 reported that the individual bands of the iliolumbar ligament are highly variable, but consistently they arise from the transverse processes of the L4 and L5 vertebrae, blending inferiorly with the sacroiliac ligament and laterally with the iliac crest. The function of the iliolumbar ligament is that it is an important structure for stabilization of the lumbosacral junction. It has also been noted by some authors that the anterior or the ventral band of the iliolumbar ligament plays an important role in restricting sagittal mobility of the sacroiliac joint. The contents of the intervertebral foramen include the sinuvertebral nerve, the spinal nerve, the recurrent branches of the dorsal and ventral rami, the dorsal root ganglia, the spinal artery, veins, fatty tissue, the dural sleeve, and lymphatics. The boundaries are anterior, the posterior aspect of the vertebral body, the posterior longitudinal ligament, and the posterior annulus fibrosus. The superior and inferior boundaries are the pedicles of adjacent vertebrae. Posteriorly, the boundaries are the inferior articular processes and lamina of the vertebrae above, and the superior articular process and lamina of the vertebrae below, with the associated ligamentum flavum and Z-joint capsule. The lumbar nerve roots and spinal nerves pass through the wider superior portion of the intervertebral foramen. The relative size of the spinal nerve and the nerve roots varies from level to level, and this is important with respect to the risk of that spinal nerve to nerve root compression. As an approximate rule, Taylor and Toomey suggest that the cross-sectional area of the intervertebral foramen increases from L1-2 down to L4-5, but the L5-S1 foramen is smaller than the rest. But the L5 spinal nerve is the largest. Therefore, the L5 spinal nerve occupies about 25 to 30% of the available area in the intervertebral foramen, while the other lumbar nerves occupy anywhere between 7 to 22%. This makes the L5 the most vulnerable to foraminal stenosis. Considering the innervation of the lumbar spine, the pain-sensitive structures include the outer one-third of the annulus, the longitudinal ligaments, the posterior capsule of the facet joint and the accompanying synovial folds, the subchondral bone and the vertebral periosteum, the anterior aspect of the dura mater, and it's questionable whether the internal structure of the vertebral body is pain-sensitive. Those structures that are not innervated include the nucleus pulposus, the articular cartilages, and ligamentum flavum. Each zygapophyseal joint receives a multiple innervation. The medial branch of the dorsal ramus supplies the Z-joint above and below its course. The capsules of the Z-joints are also richly innervated with encapsulated and unencapsulated and free nerve endings. These nerve endings suggest a proprioceptive and nociceptive function. Direct branches of the ventral rami enter the posterior lateral corner of the discs. The other sources of nerve innervation are the gray rami communicantes, which send branches to the discs across their lateral surface and at their posterior lateral corner. The picture on the right shows the dual innervation from the medial branches of the dorsal rami to the lumbar zygapophyseal joints. The intervertebral disc consists of 3 units: the annulus fibrosus, the nucleus pulposus, and the vertebral end plate. Now, let's look at each of these units separately. The nucleus pulposus makes up 40% of the disc. It is a semi-fluid gel with the consistency, more or less, of toothpaste. It is made up of 70 to 90% water, and collagen constitutes 15 to 20% of the dry weight of the nucleus. What are the functions of the nucleus? Its fluidity permits the formation of the mobile segment. It helps to disperse pressure and allows even distribution of compressive forces across the discs. And 3, it is a viscous gel and so therefore contributes to a dynamic hydraulic suspension system. The nucleus is like a balloon filled with water. If it is subjected to any pressure from any direction, the nucleus will attempt to deform and will thereby transmit the applied pressure in all directions. The annulus fibrosus is the fibrocartilaginous ring that surrounds the nucleus. It tends to be more fibrous and elastic peripherally and more cartilaginous in the inner part. The outer annular laminar fibers can be considered to be ligamentous. They unite the vertebral rims and resist tensile forces. They have a low proteoglycan content. The inner annular fibers, however, are cartilaginous and have a more load-bearing role, and therefore have a higher proteoglycan content. The annular fibers are gathered in concentric lamellae, as can be seen here, with successive layers overlapping in alternately oblique directions. The microstructure of the nucleus and the annulus are similar, consisting of water, collagen, and proteoglycans. The differences lie in the relative concentration of these components. As we can see here on the right, the nucleus contains more type II collagen, which is more elastic in nature. The annulus contains more type I collagen, which is more tensile in nature. The functions of the annulus fibrosus are: 1, it is the chief structural unit between the vertebral bodies. 2, it retains the nucleus. 3, it restricts and regulates movement. And 4, it absorbs the shock of compressive forces. The hyaline cartilage end plate is a layer of cartilage approximately 1 millimeter thick. It is attached to the vertebral body by a thin calcified layer, which is penetrated by small vascular buds. It covers the nucleus pulposus entirely, but peripherally it fails to cover the entire extent of the annulus. The functions of the vertebral end plate is that it provides a pathway for diffusion of nutrients to the disc, and it is a barrier between the avascular proteoglycan-rich nucleus and the vascular spongiosa of the vertebral body. The mechanism of weight transmission, as described by Dr. Taylor and Toomey, is as follows. Compression raises the pressure in the nucleus pulposus, and this is then exerted radially onto the annulus fibrosus, increasing the tension in the annulus. The tension in the annulus is exerted back onto the nucleus, preventing it from expanding radially. The nuclear pressure is then exerted onto the vertebral end plates. Weight is borne in part by the annulus fibrosus and by the nucleus pulposus. The radial pressure in the nucleus braces the annulus, and the pressure on the end plates transmits the load from one vertebrae to the next. Aging lumbar discs do not generally become thinner and bulge. When thinning and degeneration are found, it is most often at the L4, L5, and L5S1 levels. The central disc height is usually maintained, and it may even be increased due to the central expansion in an osteoporotic vertebrae. With aging, the nucleus becomes less well differentiated from the annulus, both in its water content and histologic structure. The nucleus, as you can see here, becomes more solid, dry, and granular. The nucleus becomes less able to transmit the load, and so a greater share of the load is then borne by the annulus. The annulus is then subjected to greater stresses, which is shown in the development of circumferential tears and posterolateral radial fissures. This macroscopic transverse section through the lumbar spine illustrates internal disruption of a lumbar intervertebral disc. The pathoanatomical changes in the lumbar joints, which are thought to occur during stage 2, the instability stage, according to Kirkcaldy-Willis in 1983, are 1, fibrillation and subsequent loss of the articular cartilage of the Z joints, 2, laxity of the capsules and attenuation of the ligaments, 3, fracture of the articular process with strain deformation of the neural arch, 4, circumferential annular tears progressing into radial fissures, which can result in herniation of the nucleus pulposus, which progresses on to internal disruption of the disc, loss of disc height, and then eventual resorption. And 5th is sclerosis of the adjacent vertebral bodies. Can you identify this muscle in the lumbar spine? This is multifidus, and in the lumbosacral region, the deepest fibers of multifidus arise from the posterior inferior aspect of the lamina and the articular capsule of the Z joint and insert onto the mammillary process 2 levels below. The superficial fibers of multifidus insert 3 levels below, such that those arising from the L1 vertebrae will insert onto the mammillary processes of the L4, L5, and S1 vertebrae. Within the pelvis, the multifidus muscle also attaches to the deep lamina of the posterior thoracolumbar fascia. Tendinous slips of multifidus also pass beneath the posterior sacroiliac ligaments to blend with the sacrotuberous ligament. Hydes et al. In 1995 noted that the cross-sectional area of multifidus increases progressively from L2 to L5. In an extensive literature review, McDonald et al. In 2006 pooled the results from multiple studies that investigated multifidus's fiber composition, and they noted that both the deep and superficial fibers of multifidus have a greater percentage of type 1 than type 2 muscle fibers. The erector spinae is a collective name for several separate muscles that extend the spine. Bogduck has divided the erector spinae according to the regional attachments, and they include longissimus thoracis pars lumborum, longissimus thoracis pars thoracis, iliocostalis lumborum pars lumborum, and iliocostalis lumborum pars thoracis. The quadratus lumborum muscle lies deep to the erector spinae and lateral to psoas. It arises from the transverse process of L5, the superior band of the iliolumbar ligament, and the iliac crest. The most lateral fibers ascend to insert into the lower anterior aspect of the 12th rib. The thoracolumbar fascia is an important structure when considering how loads are transferred between the trunk and the lower extremity. Several muscles attach into the thoracolumbar fascia and can affect its tension, including transversus abdominis, internal and external oblique, the gluteus maximus, latissimus dorsi, the erector spinae, multifidus, as well as biceps femoris. The muscles of the abdominal wall we need to consider are 1. Transversus abdominis, 2. Internal oblique, and 3. The external oblique. Let's now look at the biomechanics of the lumbar spine. In the lumbar spine, the coronal axis for sagittal plane motion is dynamic rather than static, and it moves forward with flexion, such that flexion couples with a small degree of anterior translation, 1 to 3 millimeters. Conversely, extension couples with posterior translation during extension of the trunk. Osteokinematically, forward flexion consists of two components: anterior sagittal rotation, 8 to 13 degrees, and anterior translation, 1 to 3 millimeters of translation. Arthrokinematically, the zygapophyseal joints glide superior and anteriorly during flexion. The anterior sagittal rotation of the superior vertebrae is resisted by the Z-joint capsule, 39%, ligamentum flavum, 13%, the supraspinous and interspinous ligaments together, 19%, and the intervertebral disc, 29%. The primary role of the zygapophyseal joints is to resist this forward translation and thereby maintain stability of the lumbar spine as it leans forwards. In joints with flat articular surfaces, the load will be borne evenly across the entire articular surface. But in joints with curved articular surfaces, the load is concentrated on the anterior medial portion of the superior and inferior articular facets. Osteokinematically, extension consists of two components: posterior sagittal rotation of the superior vertebrae and posterior translation. This is limited when the inferior articular processes are forced against the lamina of the vertebrae below. Arthrokinematically, the zygapophyseal joints glide inferior and posteriorly during extension. This slide illustrates the dense staining of the adult pars interarticularis, which indicates its response to loading during extension of the lumbar facets. Axial rotation involves a twist of the spine, which is accompanied in vivo by an element of lateral flexion. This movement initially occurs about a vertical axis through the posterior one-third of the interbody joint, until there is impaction of the contralateral Z joint. The axis then falls through the impacted Z joint, and movement continues as the intervertebral disc undergoes lateral translation and the contralateral Z joint distracts. The fibers of the annulus fibrosus that are inclined in the direction of the rotation are stretched, the others are relaxed. The Z joints seem very well positioned to limit the rotation and protect the disc from rotation greater than 3 degrees. Microfailure of the annulus is thought to begin at about 3 degrees and macrofailure at 12 degrees. Axial rotation is resisted by the intervertebral disc 35% and by the posterior elements 65%. That includes the articular facets, the neural arch, and the ligaments. Torsional injuries result from excessive rotation combined with flexion. Forced rotation beyond 3 degrees stresses the annulus fibrosus and the zygapophyseal joints. Impacted Z joint trauma can include compression injuries, such as fracture of the subchondral bone, fracture of the base of the inferior or superior articular process, or fracture of the lamina. On the opposite facet, avulsion injuries such as capsular ligament avulsions or avulsion fractures can occur. The intervertebral disc can undergo torsional and lateral shear strain forces, resulting in circumferential splits between the outer lamellae and avulsions of these lamellae. With repeated injuries, the deeper lamellae may be disrupted, eventually forming radial fissures. This slide illustrates some of these torsional injuries. On the right, we can see the circumferential fissuring in the annulus fibrosus, and on the left, we can see the compression of the right facet and the distraction of the left facet. Side flexion is a complex motion which is coupled with rotation. The translation of the superior vertebrae is in the same direction as the side flexion. Lateral flexion in the lumbar spine involves complex and variable combinations of lateral bending and rotary movements of the interbody joints and the zygapophyseal joints. The jury is still out. Some authors believe that from L1 to L4, lateral flexion is associated with contralateral rotation. But is this consistent in flexion and in extension? Most of the literature supports that at the L5S1 segment, side flexion is coupled with ipsilateral rotation. When we look at coupling in the lumbar spine, we should consider that side flexion and rotation is a single motion which occurs about an oblique axis. The direction of coupling may vary, and it is dependent upon a number of factors, such as the segmental level, the starting position, the muscles that are being recruited, the individual movement patterns, and if there are any pathomechanics with the disc, the Z joint, a ligament, or a muscle. In axial compression, both the annulus fibrosus and the nucleus bear the load and transmit it to the vertebral end plates. The end plates are the weakest component and they will fail first. The zygapophyseal joints participate in resisting compression in prolonged standing and with a lordotic spine. The vertebral body's ability to resist compression is enhanced by the blood in the interosseous veins and marrow spaces. As can be seen here, a disc injury from a compression mechanism may be associated with an end plate fracture or a vertebral wedge fracture. This slide illustrates the changes that can occur in the posterior annulus after repetitive mechanical loading in backward bending and compression. We can see the hairpin bending of the posterior annulus, whereas the nucleus appears normal. Failure to compression loading can result in subchondral bone or end plate fractures, which can eventually lead to the formation of Schmorl's nodes, as can be seen here. We can also see a loss of disc height, osteophytic formation, facet subluxation, facet arthrosis, and also injury to the disc, such as resorption, eventual sclerosis. This concludes this presentation on the functional anatomy and biomechanics of the lumbar spine. The next 2 slides is a quiz with 10 questions to test your knowledge.